Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
All right, Turd community, welcome back. We just did a recording on Eosinophilic Esophagitis, which was brilliant. Go back and listen to it. But we wanted to follow that up with a case today that our very own Dr. Kapadia prepared for us that kind of gives some clinical insight into how we manage it. Take it away.
All right. So this is a case I put together so I could get free food at the recent conference.
Nice.
The Gastro-EMP conference. Best GI conference in the country.
Shout out to the
And very good
Gastro-EMP.
food generally as well.
Yep.
Yes.
There was a one breakfast with, there was eggs, there was stewed black beans, there was guacamole.
Oh, so
It was
good.
a good one.
There was
Yeah.
dairy, but on the side.
Yeah, it was not on my
Classic.
food. Anyway, so do anything for free, healthy food. Moving on.
I just want to say we're all doctors, and yet we're still always looking for free, healthy
That's
food.
right.
My
That's
cousin said I'm the only doctor he knows that's always looking for free housing for the past 20 years.
I feel like that's just your backup plan. Like you never utilize it. You just have a lot of
I
backup
like
plans.
to make sure
Yeah,
that it's
you
an
like to-
option, you know?
Just to be safe.
All
Okay,
right.
so here's the case.
So, 45-year-old male with a history of bloating and dysphagia for about the past year. I think I already said 1 year. He already had an endoscopy. It showed EOE, eosinophilic esophagitis, possible hiatal hernia, erosive gastropathy. So he had been on aspirin for primary prevention of heart disease, which we no longer really do.
Right.
So, we took him off of that. Unfortunately, it probably was the cause of the erosive gastropathy. But he didn't have any active bleeding, no alarm signs, but he was having bloating every time he ate anything.
Water?
Not water, but eating pretty much anything else.
That's a great question, Dr. Sand. Yep, that's a super important question.
Good normal bowel movement every day. No nausea, vomiting, no constipation, diarrhea. He had a food sensitivity test done with another provider that we'll talk about, an IgG test. And then he had done a FODMAP diet, which didn't really help anything.
A low FODMAP diet.
Right. A
Yeah.
full of FODMAP diet.
Yeah.
Did not help.
That didn't help?
Only beans.
And
Beans
then he was trialed on omeprazole for a couple months.
Ooh, did it work?
Well, it was mostly for the erosive gastropathy,
Oh.
but it did not help his bloating dysphagia symptoms.
Did he have heartburn?
He did not have heartburn per se. He had dysphagia.
Yeah.
He had trouble swallowing, and he had bloating. He didn't really have reflux per se. So, his labs were generally normal, CBC, CMP, all of that. His IgG did show casein, several dairy markers, soy, egg, almond, and lima bean.
I just want to say, because of the episode that we did 2 weeks ago, that we put out 2 weeks ago, that list, it's just making all of my light bulbs in my brain go off. It's dairy, check. Soy, check. Wheat,
Right.
check. Nuts, check.
I know, you're
Yeah.
right. But yeah, even though that study I mentioned showed that these tests don't correlate, it
This time.
seems to help sometimes. So he did have mild asthma. He would get recurrent bronchitis once a year, post-nasal drip for decades, nothing really worked for. And so he had to take antibiotics annually for this recurrent
No.
bronchitis.
So the asthma, we're thinking that's an eosinophilic condition. Bronchitis, lots of antibiotic use. And so that's shifting his microbiome and also the cytokine responses because the microbiome is shifting.
Right. And so we talked about, thinking about EOE when someone has these concurrent allergic issues like he did. So initially, Well, we know this is like a particular type of case, but initially we did do more broad testing.
SIBO testing?
We did SIBO testing through the GI doctor. We did fungal candida markers, and this was the first visit. We ordered those. And then we did a trial of the 6 food elimination diet for 3 weeks is what I did.
SIBO positive?
We don't know yet because this is the first visit, Rebecca.
Oh, okay. Rebecca's getting ahead of herself.
So I wanted to start him on something. He's like suffering, So he agreed to do the 6 food elimination diet.
Was he already restricting food to begin with?
No.
Completely open diet?
Yeah.
Okay.
Except for the trial of low FODMAP.
Right.
So, and then I asked, I told him to ask his GI doctor, can we switch the PPI to famotidine? And they were good with that.
So can we switch from a PPI to an H2 blocker?
Right. So we switched him to an H2 blocker. And then I also started cromolyn with him. And I had him start with 4 vials a day in a big, dark colored stainless steel container, drink it throughout the day.
Wait. Stop. You did not work him up from like 1 vial, 2 vials, 3 vials. You just started him high.
Well, I think I usually do a test dose. So I probably had him make sure he wasn't allergic to it.
Uh-huh.
And then I had him do 4 in a container for a day. And then I told him if that doesn't work, do 8.
So that's a good question because people usually feel crummy for 5 days starting cromolyn?
Not always.
I would say like a third of people don't feel so high.
He was not a sensitive patient.
Okay.
I mean, outside of this condition.
So why are you doing 1?
I feel like, okay, so I usually start lower because A, I'm not sure if it's going to work. And B, I know allergists are sometimes starting their people with like a third of a vial, a half a vial.
Well, have them do a test dose and make sure they're not reacting to it.
What's interesting to me about cromolyn sodium is the serious side effects are pancytopenia and then anaphylaxis. Because I think you're dealing with an anaphylactic predisposed population. And so
doing a test dose is important.
And your test dose is 1 vial.
I probably change it. It's probably like half to 1 vial. Make sure you tolerate it. Knock on wood, no one ever had an allergic reaction per se.
Yeah,
it can happen.
I've also never seen pancytopenia.
Yeah,
but it says that's two serious risks.
Right. So always give a test dose, and then, like I said, he was not a sensitive person in general, so I had him do the 4 vials in the water bottle for the day.
Okay. And that's such an easy way to do it.
Right.
Like, because usually you dose it, or at least I've been dosing it. I'm going to switch this. I've been dosing it to 15 minutes before meals.
It says that, but when I asked around, like, to the allergists and such, they kind of said it doesn't matter as much. They can just sip it throughout the day.
That seems like it would work so much better.
But I do have them do the trial before meals if the way I'm saying doesn't work. And we think it's like obviously with this, we're thinking it's a food reaction.
That's my thing. If you get bloated right after eating,
there's probably more than one thing going on, and the EOE is not your only problem.
Yeah, well.
But I will say my problem is compliance, and this way would get such better compliance.
It's like so hard to take something before you eat.
Yeah, and especially 15 minutes before you eat.
And if you're like sipping it throughout the day, you're getting some coverage.
Right.
Okay, so wait, before you move on, my second follow-up question is, so usually I say 1 vial in 8 ounces of water. 1 to 2 vials and 8 ounces of water. Are you continuing?
I just tell them their water bottle for the
27
day.
ounces.
Yeah, like something larger, several cups of water.
I have people get the dark container and have like a separate water bottle that they drink their cromolyn throughout the day because I want them drinking more water during the day.
Right.
But that's like their cromolyn water bottle that they're sipping in addition to their whatever ounces I need them on.
I just have them put it in their water bottle for the day, whatever that is.
Okay.
I don't usually specify an exact amount. I'm assuming it's several cups of water.
Enough water.
They could drink more water, Rebecca. I'm not restricting their overall water intake. Okay. Right. So that we start with we did the test dose, start with 4 vials a day. I did tell them you can go up to 8 vials if needed. And then what we did after that, basically. So the second visit, he came back and he said there was no change with 4 vials a day, but when he went to 8 vials a day, he had 75% resolution of his symptoms.
That's really good.
Great.
This was along with food elimination. So 4 vials a day with food elimination still did not do it.
Wow. And you did the 6 elimination or just the dairy elimination?
I asked him to do the 6.
Because that's what came up on his IgG.
And I think it's probably just the way I think like a third of the people are going to have more than one thing. And he seemed open to doing more. I think 2/3 of people are going to have 2/3 are going to have more than one food issue. So his bloating was much better. And, I don't know that he actually removed all those foods. He definitely removed egg and dairy, and those turned out to be triggers. So I think he kind of did a shorter term with the other ones. And then I don't know if it was intuition or what, but he did keep out eggs and dairy, and had the 75% improvement. His asthma also was better.
Wow.
So we gradually added back, and then we added the egg back first. That seemed okay. When he tried any kind of dairy, he got more bloating and esophageal symptoms.
Wait. So let me just back up. His bloating and his dysphagia both got 75% better.
Yes.
Whoa.
Yeah, 75%
that's awesome.
better.
That's awesome.
And then we did switch him to Pepcid, the H2 blocker, instead of the PPI. His SIBO test was negative. His Candida antibodies were negative. Celiac was negative. Everything else was pretty good. And I'll say, actually, his SIBO test, not the best test. His methane was 7 at baseline, but there was no jump.
So I think that I guess the way I view methane is not controlled by the diet. It does its own thing. So a higher baseline methane, just as he's more likely to have methane or intestinal methanogen overgrowth.
Okay. So yeah, the rest of this, it seemed to be a primarily food allergy based issue. I did do stool testing. He did have protozoa. I treated him with tinidazole, but he had no change in symptoms. His stool test did show yeast, even though the Candida antibodies were negative. So I was going to consider treating him for that if he had persistent symptoms, but he didn't. I mean, it was 75% or better.
Right.
Basically, then the cromolyn was on back order. So we switched to ketotifen.
Right.
And that gave him just as good improvement with no side effects.
And easier to take.
Yeah.
See, and I don't always see that happening when I use ketotifen. Like I think,
it usually has more challenges.
Well, I think of
People sleep well.
People sleep great. It's magic for sleep. I think of ketotifen more like I would assume it would help the asthma. I would assume that it would help like hives or any kind of like that. But it's not as powerful for the GI tract as cromolyn.
I don't know. I think I see it work better.
Really?
I've had like 2 or 3 males that had diarrhea. Nothing touched it except ketotifen.
Well, and there are studies in Europe where it was used for prevention of anaphylactic reactions. And
that makes sense.
It had efficacy if you were taking it regularly, that it prevented an anaphylactic reaction from developing.
Yeah.
I mean, it's got such a damn long half-life. Like that makes sense.
I thought it doesn't have a long half-life.
So you can't find we can't tell in the US, like because ketotifen is only a topical eye drop.
Yeah.
But when I look at the data in Europe for half-life, it's somewhere between 13 and 23 hours.
Okay.
I mean, anyone who's taken it at 9 p.m. will tell you that.
I tell patients to take it at 5 p.m.
Right. But I mean, the hangover.
Yeah. Oh my God, the hangover. It's like a thing.
Yeah.
It's so weird. Some people have no hangover.
I think that if you are very histamine-y, then probably you don't have a hangover. But if you're taking it like I am, like off-label for sleep improvement,
I could 0.25. I'm like sleeping for 20 hours.
0.25 is the dose that I take also. Yeah.
Again, or kind of delicate flowers here. But what about Montelukast?
You could consider that as well. It's not like my go-to, I guess, just since they put that label on there for behavioral, concern for mood issues. Not that everyone by any means gets that, but it's just the H1, H2 cromolyn and ketotifen, if they tolerate it, are quite safe.
Montelukast is an H1?
No, it's a whole different. It's a leukotriene inhibitor, I believe. I don't use it very often, actually.
I've had, there are allergists, I think, we all sort of work with who prescribe them a lot. And I've had a lot of patients more recently who just refuse to take it.
Because of the mood stuff.
Yeah.
What's the mood label?
I don't remember. It's like
I think increased risk of depression.
I think it's more serious than that.
Yeah.
Like it scared them enough. And, a lot of people already have anxiety or depression because welcome to America. But it's...
it's like the movie.
Reasonable. Yeah.
So different from the movie, huh? Welcome to America. That was a good one.
Wait, who was that?
It was so good.
Yeah.
I don't remember.
Yeah, Eddie
Murphy.
Eddie Murphy, yeah, okay.
Such a good movie.
That also makes us very low. Very old. Okay, guys. So I'm just looking very quickly at the side effects of Montelukast.
What's the black box? Look at that.
Neuropsychiatric events, highly variable serious reactions, agitation, aggression, depression, sleep disturbance, anxiousness, disorientation, attention disturbances. Wow, this list goes on and on.
You know what I found out recently for varenicline for smoking cessation? They took off the FDA warning like 5-6 years ago.
Is that's brand Chantix?
Yeah.
Huh.
Interesting. Side note.
So I have a question about, we've talked about the microbiome and how the sinus passages play a role in this. And when we're talking about respiratory allergens and how it affects the esophagus, is there any role for like sinus sprays or microbiome testing in the sinuses or anything with,
yeah,
just
I mean,
because
if you're
it leaks into the, like
Yeah.
that specific part of the digestive tract?
I think that's like step 4 or 5. Like after you figure out the foods, you get them on a stabilizing program so they're not having symptoms, hopefully, like
Right.
with the meds, and then you can go it after the underlying things. I mean, I did order the other gut testing initially, but I think that's a good thought to consider working on the sinus microbiome if they have symptoms. If they have no sinusitis symptoms,
People have postnasal drip for like decades and normalize it and not,
It's
you know,
true.
and that's seeding
yeah.
inflammation and
Yeah,
dysbiosis and
it's
phlegm
true.
and I
It's
mean,
so true.
so I would think about that for these folks. Like, what else is contributing to
Okay,
grossness?
Yeah.
grossness. Yeah, that's very medical.
Yeah.
Yeah. We
I'm
should.
pretty sure that's the right
Yeah,
term.
yeah.
Postnasal drip is not fun. I'm getting over a
No.
virus from 2 weeks ago and it's still getting me.
Yeah.
Okay, just so this whole conversation actually has changed my view of EOE. So thank you so much.
Okay, good.
Because it's just like, let's say, but thus far we think of EOE as a diagnosis based on biopsy. My question is, let's say somebody walks into your office with just dysphagia.
Yeah.
Like it's not GERD, it's just dysphagia. Are you likely to do what you did with him, which is just start with a dietary piece?
Well, the problem is if it is EOE, we want to know because I mean, this is always the thing, right? Do we need the diagnosis first?
Yeah,
like with
and I'm
celiac
struggling
disease.
with this.
I know it is a tricky one because it takes so long to get the endoscopy, but the good thing is that often people already have had an endoscopy and have the diagnosis. If they don't, it becomes much trickier because it's like, do you want to confirm if it's EOE? Because otherwise, if we start treating it, are they still going to have the 15 eosinophils on high power
Right.
field? You know, like maybe that goes away. But then what is the benefit of knowing they have the diagnosis? I think if they had stenosis, that's not going to go away just from us treating it. So I guess we'd still see that on endoscopy, but we wouldn't know that it was from the EOE.
Dysphagia, like that can get pretty red flaggy quickly.
Put it, because I feel like a lot of people come in with dysphagia.
Well, if it's at 30, let's say it's a 30-year-old and you're waiting, because we're usually waiting
Yes,
on the
that's the
endoscopy. So
problem.
it's like, do you start treatment
Yeah.
while you're waiting? And that's much harder because I don't want to change the biopsy results.
Right.
you
And
know?
I will say that is exactly where I get caught.
It's tricky.
And I have a patient, like I got caught in this. I had a patient, he was suffering. He was having bowel accidents. He was suffering. It was obvious to me he had microscopic colitis, right?
Yeah.
I did a calprotectin, it was negative. And so I started him on budesonide and he stopped suffering, but then he went in for the scope and it was normal.
Yeah,
You
so
know,
now
like-
you don't know if it was
Right.
microscopic.
Well, yeah,
colitis.
and it just like they're like right now they're like 3 months out, and that like right now we're also dealing in a saline shortage, so they need saline for all their
Yeah.
drugs. Like that's going to put them even
I
further
know.
out.
I think if we had a more common sense approach to medicine, we would probably treat the symptoms. If they went away, do you need the EGD? Because
Right.
if your dysphagia resolves
Right.
with simple like cromolyn
Right.
going off dairy, you don't really need the EGD. But in an older person, it is a red flag symptom, and we need to rule out something more serious. So, you know, I don't have a great answer for that. I think in a younger person, it would be easier to convince myself to just try treating them. They can still go for the EGD. Of course, if they're completely asymptomatic, maybe we cancel it. In an older person,
Define older, 65.
it probably changes as our age changes. Currently, it's above 50 or so, but
So,
then it might shift.
I have heard that old is 20 years older than you are right now.
Yep, sounds about right. Yeah, what do you do? An older person, you ordered the EGD, you're waiting for it. Do you treat them symptomatically? And if they get better, do you not get the EGD?
I mean, I do think something that you just said really resonated with me, which is if we had a more common sense medical system.
Because then what if they're telling me they're better, but they still have some symptoms and they end up having an esophageal mass or a stricture that, you know.
So I guess from right now where I'm resonating is what I would do is I would start this protocol. I would start the diet, especially, you know what I mean? I might start some of the topical agents and I would put in the referral for the endoscopy and I'd wait 3 to 6 months.
There are algorithms for evaluating dysphagia. like solids or liquids,
Right,
time of day, like, things that can help you kind of hone in on how serious this could be. And if any of those also change with treatment
Right.
too, like which ones
Yes.
change might help.
Yeah, I feel like in older people, it's always. I mean,
It's
any
more
kind of
serious.
dysphagia,
Yeah.
you just need an EGD. But yeah, in younger people, is it postnasal drip? Is it
Right.
like other? Yeah, it can be so many different things. That globus sensation sometimes people describe as dysphagia.
And then I will also say, as a flip side to that, I am seeing people come in with EOE younger and younger.
That's true.
Like,
That's true.
I think that we're messing with the microbiome on so many different directions.
And we're all inflamed.
And we're all inflamed because we live in a toxic sludge of a world that I feel like I am seeing it younger and younger.
Yeah, and I mean, I will mention, if someone has like several different food sensitivities and it's not a sustainable diet, obviously in the regular medical world, you would use budesonide and these agents, right? In you may also consider referral to the allergist in that situation to see if you can knock down the allergic
But
load
again,
that way.
that's 3 to 6 months out.
Right. But I'm saying long term.
Yep.
Yeah. And then in the integrative world, you can explore, there's other ways to help people resolve food sensitivities, and whether that's through just working on their microbiome or targeted sort of alternative allergy treatments. There's all sorts of things that are available that we're not going to go into detail here, but it's not hopeless if you end up having like 5 things causing your EOE.
Right.
See an integrative naturopathic functional medicine provider.
I also
too.
like, in general, all of us, I think, have histamine related conditions on our radar way more than we ever had to, especially in the gut, because it's, a lot of what we do. But I think, starting with some of our histamine things without a formal diagnosis for bloating, like you said earlier, we of course test the microbiome. We of course talk about diet and all of that sort of stuff. But I have a lot of patients where it's just histamine.
Right.
It's just histamine. And things like cromolyn or even our herbs.
So that brings me back to, you said, does he bloat just from water? And I said, that's a great question.
Yeah.
We should explain why that's a great question.
Yeah.
Why is that a great question?
Because that's like almost my screener for histamine.
Yep.
If you put anything in your gut and you're bloating, it's like this reactivity that to me seems pretty pathognomonic with histamine.
And the thing about histamine is you have histamine on the skin. You have histamine in the GI tract. You have histamine in the lungs.
All your food.
You have histamine in the vasculature.
Yeah.
I mean, it's like histamine is everywhere. And we are seeing more and more people who do not regulate their histamine.
Right. And the thing that I really get, especially a lot of buy-in with patients, like people are very relieved to hear this, is histamine is a neurotransmitter.
Mm-hmm.
It's an excitatory neurotransmitter.
Yeah, you don't want to knock it down too much, too.
Right. Because then you're sleep.
You go to sleep.
Yeah.
Which is why.
Hence ketotifen, sleeping for 24 hours straight.
Some other sniff one.
Yeah, but like...
I'm having sniffs. I think there's a snip with ketotifen.
But I think it really helps patients to know that, because a lot of these people will also have anxiety.
Yes.
I mean, everyone has anxiety, but people's anxiety, I do see it get better. Like, people can regulate more easily treating their histamine conditions.
Completely. Yeah. Absolutely. So. Because it's an excitatory. I always talk to people about how 10% of their neurotransmitters are excitatory and 90% of their neurotransmitters are GABA based, trying to turn off the other 10%.
Right. I know.
Like, and in our world where just by the nature of how we live, it's so much more excitatory. Yeah. And then you throw in a tad of the mast cell in there, it could just be bad news bears.
It is.
Yep.
Totally.
That was a great case.
The last thing I'll mention is they are now using biologics for EOE.
I was going to ask that.
So if you do, I think getting them to the allergist would be the way to go. They're the ones who, I'm sure there's other fields as well, but I don't know if GI also is probably also using biologics, but there's a couple. When I watch football, I see all the pharma ads. That's how we get most of our medical education. So there's now a new drug where they're super happy. They're doing lots of things. Yeah.
And then in the background, and these are all the ways that you can possibly die.
Right, and my husband is like, oh, I want to take that one. What's that one? It looks like another good one. So anyway, there are biologics for EOE as a, sort of last resort.
So in this case, did you treat the fungus you found?
I was going to, but he got so much better. Right. His Canada antibodies were negative. It did show in the stool, but we know that's sort of like maybe not. It's a problem. We're not quite sure. So because he was doing so much better, and it just seems so food related for him,
and possibly if you set the microbiome up to succeed, you could kick it.
And I did forget to mention. I probably forgot to tell him this, but he realized on his own that if he chooses food, and eats slower, it was also better. So
who saw that coming? Who saw that coming?
What?
That was a great case.
Oh, that was.
Thank you, Dr. Kapadia, for presenting EOE.
Hash through all that.
Thanks, everybody.
Thanks.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.